Good afternoon. I am Erica Daniels. I am the founder of Hope Grows for Autism. We're a nonprofit, and our mission is to improve the lives of families affected by autism through research, education, and advocacy of cannabinoid medicine. In 2016, I discovered that cannabinoid medicine greatly improved the quality of life for my son, Leo, who is significantly affected by autism. Sadly, we turned to cannabis as a last resort after years of unsuccessful treatments. And the results were so profound that I made it my personal mission to work to bring cannabis to light as a frontline treatment for autism. Today, I am very, very excited and honored to have a very special guest tonight with us, Dr. Bonni Goldstein. Dr. Bonni Goldstein is the owner and medical director of Canna-Centers Wellness and Education, a medical practice devoted to educating patients about the use of cannabis for serious and chronic medical conditions. Dr. Goldstein has her new book out, Cannabis is Medicine, and please visit her website, drbonnigoldstein.com, to learn more about Bonnie's work and about how to order Cannabis is Medicine. We do have several signed copies for our attendees of the webinar tonight. So without further ado, here is Dr. Goldstein. Thank you for coming and welcome.
Thanks so much, Erica. I'm going to go ahead and share my screen and get my PowerPoint up. So bear with me here as I negotiate the technology.
Understood.
There we go. So can you see my screen?
I can.
Okay, great. So thanks to everybody for attending. I'm going to talk about medical cannabis and autism. And I'll just get into it here. So I trained in New Jersey at Rutgers Medical School, and I moved out to California to do my internship and residency at Children's Hospital Los Angeles, where I was chief resident. And then I worked in critical care transport as well as pediatric emergency medicine for many years. In 2008, I had my first kind of exposure to medical cannabis when a friend of mine who was quite ill asked me about medical cannabis, and as a physician, I knew nothing, and it was quite embarrassing, actually. So, especially in a state that had the first law that began in 1996. So, I did some research for her, and I was absolutely amazed to find out about a system called the endocannabinoid system that I never learned about, that we all have, and that plays a very large role in our health. And so I delved in. I'm a bit of a science geek and decided just to become a cannabis specialist. And so I started working in the field in 2008. I opened my practice called Canna-Centers, and since then I've seen over 18,000 adults and over 1,000 children. Right now I specialize in children mostly due to my pediatric background. It's kind of my passion. And then last year 5 years ago, I self-published a book called Cannabis Revealed, and then just recently Little Brown picked it up and I revised it. It is the latest and greatest, up to date as best you can in this world of evolving information. And it's called Cannabis is Medicine. It was just published about 2 months ago, and it goes through a lot of what I'm going to talk about. So if you're curious to learn more, it's a great resource for you. Now let's jump into autism. So in the United States right now, we only have 2 approved medicines for autism, risperidone and Abilify. They're both atypical antipsychotics. We know that they have serious adverse side effects. And one of the biggest problems with them is they don't address the core symptoms of autism. They just have been approved to treat irritability. Which I kind of see as more of a tranquilizer than anything else. I mean, I don't necessarily see patients having developmental progress, better speech, better focus, better sleep on these drugs. What I see is that we're just kind of band-aiding the situation. And I understand that autism is a spectrum disorder. It's very heterogeneous, meaning it's very different in the way it's expressed. But at the same time, these drugs do not address the core symptoms. Now, we know other drugs are being used as well. And if you're a family with a child with autism, you probably know or have been prescribed these drugs. SSRIs like Prozac or Effexor, the drugs that help with serotonin. There's stimulants, antihistamines, anxiolytics, and other antipsychotics. But when you really delve into the literature looking at how these drugs work, the overall response is poor. There's a fair amount of side effects. And also really what, you know, I kind of joke around with people, I can sedate your child for you, but that does not make your child's quality of life better. And so there was a study in 2005 where they surveyed parents, like, why would a parent turn to complementary or alternative medicine? And it's because then and now, like this is from 15 years ago, but it's ongoing now, that there are really very few choices and nothing addresses the core symptoms. And that's where cannabis comes in. So let's see, there we go. So why cannabis? So again, focusing on the endocannabinoid system. So if you haven't heard of the endocannabinoid system, this is a system that was only discovered in 1988, and it consists of multiple parts, which we'll go over. But basically, the endocannabinoid system is a system it's how our body sends signals to keep us in balance, okay? And the system exists. In fact, it's probably working right now behind the scenes. You don't feel it. But a good analogy is like if I ate something with a lot of sugar, like a candy bar, I get sugar in my bloodstream, and my body recognizes that high sugar and spits out some insulin from my pancreas to bring the sugar down and to get me back into a balance of my glucose, right? And, you know, many of us have gotten blood tests where they have a range of what your fasting glucose should be, okay? And if you're above that, and it's determined that you don't make enough insulin, they diagnose you with diabetes. And what do they give you? They give you insulin. If it's not type 2, let's say type 1 diabetes, you get insulin because your pancreas isn't making enough insulin to bring down your sugar. So you understand that we have all these mechanisms in our body to keep us in balance. So the endocannabinoid system, its job is to help keep cells sending balanced messages. So hopefully you can see my pointer here. This right here is called the cannabinoid receptor, this squiggly blue line. What's happening is this is a neuron, and this neuron is sending a message, and see it says NT here, that's neurotransmitter like serotonin, dopamine, norepinephrine, those types of chemicals that our brain makes. And that's the little purple circles. Those are being sent from one cell to another cell. That's the messages that our brain sends. So if, let's say you took some medication that has a side effect of nausea and you felt nauseated, the part of your brain that controls nausea is sending the message to feel nauseated. Well, that's what these messages are sending. They're sending a message to feel a certain way or to do a certain thing. So what happens is those neurotransmitters get sent from the sending cell to the receiving cell. And if the message is off, the receiving cell gets annoyed and the calcium goes up, which turns on a little factory that takes healthy fat from your diet and puts it together to make your natural, what's called endocannabinoid, your inner cannabis compound. And this inner cannabis compound is released back up to the sending cell. It binds to the receptor. You can see a little green triangle here sticking on. That's how the chemical sticks onto the receptor. And then that triggers a message inside the sending cell. And you can see the little negative inside, or little minus sign inside the circle. It's basically like the volume. It's saying, turn it down, stop sending so much message. And what's happening here is this is basically a feedback loop. This is a system that helps your cells recognize, oop, too much message, let's dial it in. We often call too much message neuroexcitation. And neuroexcitation can be really anything, but we definitely know that it is what we see when we see children with autism being aggressive or self-injurious or stimming, children with epilepsy or adults with epilepsy. their brain is in a neuroexcitatory state. And so what's happening here is that in these patients, the thought process is that maybe their endocannabinoid system is not working well. They're missing the feedback, okay? Now, the receptor location informs function. So now look, these receptors are kind of everywhere in your body. That's why when you hear that cannabis can help things like pain, nerve pain, and nausea and muscle spasms, it's because these receptors are all over the body. But 3 places where they tend to be concentrated, of course, the brain, the gut, and the immune system. And when we look at issues that children with autism have, it kind of overlaps. Many of them have issues with neurotransmitter, but also they're 4 times more likely to have gut issues. And certainly we know that there's dysfunction within the immune system. So remember that this system is here and it's constantly working. It kicks in when you need it, and it helps keep us in balance. And it goes into action anytime there's illness, inflammation, or so on. And its job is to help with recovery, repair, protect, and again, to maintain balance of those messages being sent. And so the way to look at it is it's this physiologic regulator that helps keep cells in what we call homeostasis, in balance. Now, again, it's made up of numerous parts. So it's made up of the cannabinoid receptors, which I showed you what they look like sitting on the cell wall. They're also made up of what we call our endocannabinoids. These are our inner cannabis compounds that our cells make when we need it. And again, this is why a lot of people are turning to low sugar diets or high fat diets like ketogenic diet. Fat helps this system work better. Anandamide was the first compound endocannabinoid that was discovered. It was discovered in 1992. It is made up of fat. 2-AG was the second one discovered, and there's 3+ others. We think that there's probably 13 or 15 endocannabinoids still yet to be discovered. But again, endocannabinoid, just convert that in your brain to inner cannabis. It's the compounds our brain and body makes in order to maintain balance. There's also enzymes, so synthetic meaning build-up enzymes and degradative breakdown enzymes that are part of the endocannabinoid system. Your anandamide, your 2-AG, they're made when your body recognizes the need to use it. So made on demand, they do their trick at the receptor, and then these enzymes come along and breaks them down, okay? And really fascinatingly, anandamide, in a study from Stanford University in 2018, anandamide's very difficult to measure. Right now, there's still no commercial tests where you can take your child to get their anandamide levels measured. Remember, I told you, you make them when you need them, so they're not always floating around. But at Stanford, they've figured out it's a fairly complex blood test to draw blood and measure plasma anandamide. And they found that children with autism had lower levels of anandamide. If you do not have this compound, right, it's the messenger to tell your cell to send the balance message. So if you do not have enough of this, your cells cannot send a balanced message, all right? And then that finding was found again in Israel in 2019. This study was done where they looked not only at anandamide, but 2 other endocannabinoids, and they found lower circulating endocannabinoid levels. And I'm going to go into these studies in just a bit. Another study that was very interesting was, and this preceded the anandamide studies, because your receptors, remember I mentioned their brain, immune system, gut. Remember, your immune system is made up of white blood cells as part of it. And if I were to draw blood on you and pull out your white blood cells, I can look for cannabinoid receptors on your white blood cells. And that's what they did, was they pulled out, they compared children with autism with children without autism. And they looked at type 2 cannabinoid receptors. So we have a type 1 mostly in the brain, type 2 mostly in the body. There's a little overlap, but good way to remember it. And they found that children with autism had higher numbers of receptors. Now, when does your body crank out more receptors? It cranks out more receptors when your body recognizes that you are missing your endocannabinoid. It's trying to It's kind of like if you're looking for a lost child in the woods, you send out a lot of people, you don't send out one. So the body actually is saying, gee, where's the anandamide? I want to send a balanced message, but there's no anandamide. Let's make more receptors to see if we can catch any molecule of anandamide. So interesting that there are these kind of abnormalities in the endocannabinoid system in children with autism. And by the way, it's not just patients with autism. We know that there's abnormalities in patients that have migraines, fibromyalgia, schizophrenia, chronic motion sickness, seizure disorders, all kinds of other conditions where there are endocannabinoid system abnormalities. All right, moving on to the next slide. So how does THC and CBD interact with the receptors? So here, as you can see, this purple shape is the receptor, and it's saying CB1, CB2. They're a little bit similar and a little bit different. And this kind of carve out where you would put a key in, that is the site at which your endocannabinoid binds onto the receptor. And it turns out that this amazing plant makes a compound that also fits as a key. And we do not have receptors so that we can use THC. It just so happens that there is this quirk in nature where THC fits this receptor. It's a biologically active compound. Now, interestingly, CBD does not work the same way. If you look over here, the way CBD works is CBD sticks onto a different site on the receptor. So we call this site an allosteric site, and the site where THC sticks in, the orthosteric site. But basically the way you should look at CBD is it kind of regulates how tightly THC binds to the receptor and kind of changes the receptor, so it changes the way that THC can work. And we can use that to our advantage, because if you are missing anandamide, CBD, as you can see, is not going to replace it because it does not work in the same place. So CBD can help patients who have symptoms, pain, anxiety, sleep, autism, epilepsy, and so on. But if you are anandamide deficient, your body may actually need some THC in the picture. And this is why I always encourage patients to use some product that does contain at least a little bit of THC, because if you are missing anandamide and THC mimic each other, and CBD does not fully mimic. So that's very important to understand. One other thing that CBD does, which is really interesting, is CBD helps your body prevent the uptake of anandamide. So any anandamide you do make, CBD kind of blocks the way it's broken down, or slows it down, so that what we call it's a anandamide uptake inhibitor. It allows your natural endocannabinoid, your anandamide, to work better. So CBD enhances the function of anandamide. So very importantly, THC targets the receptor directly, plus it has a few other targets in the brain and body, and CBD indirectly targets the receptor. It's important to understand the difference. But we also know that CBD has a multitude of other places in the brain and body where it works. I think it's over 65 different locations. So by using CBD, it's very hard to guess how somebody's going to respond, because with 65 different targets, who knows which one is going to be the more dominant. And this is why we have to accept the fact that CBD, these compounds are not one size fits all. These compounds are not exactly the same response in every patient. Now let's just go through the literature real quick. So there is a case report of dronabinol in a 6-year-old boy. So dronabinol is synthetic THC. This was out of Europe, I believe, where they took a patient, a little boy, and they followed him by giving him drops of dronabinol. And they found that over a period of time, I believe 6 months that they followed him, he had significantly decreased hyperactivity, irritability, lethargy, abnormal movements, and inappropriate speech. And his total dose of dronabinol, this is kind of equivalent to THC, was only 3.6 milligrams. When I'm speaking with adults and using THC dosing for, let's say, someone who's looking for, let's say, just like sleep and anxiety, we start with about 2.5 milligrams, and we go up to about 10, 15, 20 milligrams, depending on the person's tolerance and how they take it and so on. So 3.6 milligrams is actually a pretty low dose, but you can see, and interestingly, they used the parents, they used a, like an independent evaluator, and I think also the child's doctor. So all three evaluators found that there was a significant reduction in all of these unwanted behaviors and symptoms. Now, there's some other research you can see in 2013, 2 studies that kind of looked at the genetic mutations associated with autism in the endocannabinoid system. Your endocannabinoid system is coded in your DNA. If there's a deficiency, if your parent has a deficiency, you can inherit that. You can also get an acquired deficiency. But there is now some research to show that there are some genetic mutations linked between autism and endocannabinoid system. Also, what was found too is that in mice, they found that if they altered the endocannabinoid system, like blocking it, there are chemicals that can be used to interact. I don't want to spend too much time here on this, but basically they found that when they messed with the endocannabinoid system, it resulted in autistic type behavioral abnormalities, which is quite interesting. And then this last study from 2016 shows that they increased anandamide activity at the type 1 receptor in the brain, improved social impairment in mice with autism. So these are, the last 3 here are mice studies, but interesting that by manipulating anandamide at this receptor, you could improve some of the symptoms of autism. Now, when we look at human studies, I've already mentioned this type 2 receptors were upregulated. And again, I'm just going to show you here in this graphic here. To the left is CTL as control, to the right AD as autism disorder. And as you can see, this is gene expression. So in the controls, there was 100% gene expression of all the various components that make up the endocannabinoid system. And in children with autism, they found abnormalities in the way that the gene expression manifested. So there was lower CB1, which is the receptor, higher CB2, and that's the title of the article. CB2 receptors are upregulated. There's more. And then FAH is FAAH is one of the enzymes that breaks down anandamide. And then this last NAPE-PLD is another enzyme. So what this shows here is just the proof of concept. There are abnormalities within the endocannabinoid system. And remember, if there's abnormalities in the system, can we target those abnormalities and try to correct them by augmenting the system with an outside source of cannabinoids? And that's the big question. So here is the study from 2018 from Stanford. And as you can see, the blue bar shows the plasma anandamide levels in the children with autism, and the yellow bar shows the levels in the control. And you can see the children in the control had higher levels of anandamide. And what's interesting about this study is that the levels in children with autism were decreased enough such that by plotting out on this graph, you could see the blue is the children with autism, and then kind of heavy down here with the gold, that the scientists who looked at this were almost able to determine which children had autism based on the blood test. And remember, right now, the diagnosis of autism is a clinical diagnosis, and we have to wait until a child is showing the manifestations in order to diagnose them. And the big question is can this be a blood test that will help as an early biomarker of potential, autism? I've had parents tell me, especially experienced parents, oh, my 4th child was different than my other kids. I knew at 6 months something was wrong, but they had to wait until the child was 3 to get diagnosed. So potentially this may be a biomarker where we can get blood work early on and then intervene early on, which would be ideal. Now, when you look here with the lower circulating endocannabinoid levels in children, again, this came out of Israel in 2019. And what you see here is that 93 children with autism and 93 controls, both groups were 79% male with very high severity scores. 80% of these children were on medication. And as you can see, looking here, in the red is the levels of, this is anandamide here, and OEA and PEA are two other endocannabinoids. And as you can see, they're statistically significantly lower than in the control groups. And this, again, helps us understand that there is this abnormality that is a target of treatment. How do we get, if you don't have endocannabinoids, can we substitute cannabis and cannabinoid compounds to get that back into balance? And again, the concept is if you're missing insulin, you take an external source of insulin. If you're low on vitamin D, if your child had a vitamin D deficiency, you would give them vitamin D. And so this is kind of the concept behind using cannabis as medicine, okay? Okay, so now additional findings, and this is, I'm just gonna go through this real quick, but they found in this study from Israel that younger and thinner children had lower levels of anandamide, although after they corrected for some of the comparisons, it didn't remain significant, but it's an interesting finding. They didn't find any other correlations with age or BMI or gender. So how much your body mass index, or whether being a male or female, it did not have any correlation to the levels of anandamide. They also found no significant correlations if there was comorbidity with ADHD, epilepsy, whether you used medications or if there was prenatal complications, which is very interesting. But they did find a tendency, although it wasn't statistically significant, that they found higher, the APSI is like a severity score for autism, where the families would answer the questions and it kind of marks off how severe the autism is. So a higher severity score or higher use of antipsychotics had lower anandamide levels. And again, not statistically significant, but a very interesting finding. And does that mean that kids who have more severe manifestations of autism, like severe aggression, severe self-injurious behavior, you know, they don't sleep at night at all, or, you know, inability to calm themselves, does that mean that they may need higher doses because their anandamide is lower? It's, you know, interesting question. In this study too, they also stated the same thing that I just talked about, which is, could the use of anandamide levels and these other two endocannabinoid levels be diagnostic biomarkers for autism to help with an earlier diagnosis and therefore an earlier intervention. Now, this is a chart that I made that reviews four recent, so you see 2017 to 2019, what we call retrospective surveys. So where patients were given cannabis and data was collected. And this first one here is out of Chile, the one from 2017 here. I don't know how to say the name, Quester, I think. They had 21 patients. 71% got a balanced CBD to THC. So that's like a 1-to-1 ratio, half CBD, half THC product. 19% got dominant CBD, meaning high CBD, low THC, and then almost 10% got high THC products with very little CBD. The treatment lasted around 7 months. That was the mean. And the outcome, about 67% of patients were listed as very much or much improved, and only 6 out of the 21 had minimal improvement. You can see the dosing range there. This is low dosing. Just, I'll share with you as a clinician who does this every day, these are very low doses. 13 milligrams a day is like practically nothing. I've got kids taking 400 milligrams or more a day, so for CBD. THC dosing, you know, I have patients that are 20 to 50 milligrams a day. So 5 milligrams, you know, 0.22 to 5 milligrams is pretty low. But at least you can see here that that 66.7% showed improvement in at least one core symptom, and the reported benefits were better sleep, less food rigidity, improved sensory, and also in those patients who had seizures as well, they saw some improvement in seizures. And in terms of the adverse effects, only agitation in 2 patients and irritability in 1, all of which resolved when they changed the product. And that's the beauty of cannabis, is it's very flexible medicine and you can change this. I will share with you that if my patients are having side effects, I know they're not on the right regimen, because they should not be having side effects from their cannabis regimen. Now moving on to the third column, which is the Iran et al. 2018. This is out of Israel. They had 60 patients. This was a really nice report, because what they did was they started the patients off at a 20-to-1 CBD to THC ratio, meaning 20 parts CBD to 1 part THC. okay? And if they did not respond, that what they did then was they added in THC given, which then lowers the ratio, right? A little more THC lowers that ratio. And they went down as low as 6-1. I'm not sure why they stopped there. I have patients taking 1-1, 2-1. We also have patients that take more THC than CBD. But in this study, that's what they did. It was a mean of 11 months. And by the way, at 11 months, there was something like, I think 75% of patients were still using cannabis, which definitely shows you that families were very happy with the results. Out for the 20-1, 31 out of the 60. So you're talking basically half, right? Responded, I think it's 52%, responded to this. And of the 29 that did not respond to the high CBD, low THC, they were given a little more THC. And in that group, another 20 out of that 29 responded. And that tells you that some kids just need more THC than others. 6 had no change out of the group, and 3 out of, this is out of the 29 that did not respond to the high ratio, 3 were worse. And again, you can see dosing. They went by weight. So 0.1 to 6.4 milligram per kilo per day. This shows you a very wide range of dosing. There are patients that are going to respond at low doses, some in the middle, and some need very high doses. And that has a lot to do with kind of your own metabolism, how much are you absorbing, what form are you taking it in, but also your own endocannabinoid system status, okay? And of course, the THC dosing, as you can see, is also on the low end. What's interesting is they reported 61% improved, outbursts 39% improved with anxiety and communication, 47% improved. Patients that were able to stop or decrease other medications, pretty high number, almost 60%. And adverse effects included sleep disturbance, restlessness, loss of appetite, GI. We can see this with high doses of CBD. Again, these can be mitigated with either altering the medication, timing, and so on. And these last two, I'm just going to show you very similar results with also out of Israel. So 188 patients in one and 53 another, 20-1 ratio for most. You can see at least 2 months versus 6 months here. And then overall, you see fairly high numbers responding. And by the way, I'll just share with you that like for the FDA to pass a drug through for pain, they have to have a 30% efficacy. So when we're seeing, you know, 50, a combination of 83% between significantly improved and moderate improved, that's pretty good numbers, okay? And as you can see, again, with adverse effects, very acceptable, restlessness, and maybe some transient somnolence, feeling sleepy or change in appetite. So really nothing that can't be dealt with. Certainly acceptable side effects in the face of what other serious pharmaceuticals can do to patients. So, all right, let's move on here. Oh, sorry. Uh-oh. Oh, I apologize. I lost it. Bear with me here. There we go. Okay. So this just shows you in graph the report out of Israel. So you can see of all patients, you can see very much improved or much improved for behavior, anxiety as well. But what's interesting is the boys, when they separate out, so the boys are in the gray, you can see boys seem to have a little bit better response, which is interesting. And again, here's the numbers. 61% for improved or very much improved for behavior, 39% for anxiety, almost 50% for communication. Stopped other medications, about a quarter of patients, and less medication or lower doses, about a third. Very interesting. And only a low number who added or increased medications. Here's the 188 patients. I already went through this, but what I want to show you here is that the benefits that the families reported: less agitation or rage attacks, better sleep, less tics, and less seizures. And by the way, in this report, they did report a side effect of restlessness. And I'm going to talk about this. CBD in low doses can sometimes be overstimulating. And if you see that, and you're not happy with that because your child who's already hyper is now even more hyper or more restless, you may say, this medicine's garbage, I'm not using it. But what we know about CBD is that when you go to higher doses, which nobody wants to do if they see low doses aggravating their child, but trust me that when I tell you that higher doses can be very calming, and that's what we call biphasic effects. Low doses do one thing and high doses do the complete opposite. And it's very important to understand that, because many of the families that come see me will tell me my child was overstimulated with CBD. I don't know what to do. I didn't think it worked. I don't really want to try it again. And when I delve into what the dosing was very low. And often when we go to higher dosing, we get the outcome that we are looking for. Okay, now this is interesting here. I just want to show you this so that if you look here, the total number of patients in this group from Israel, remember it was 188 patients, 55% of patients were on antipsychotics, 46% were on antiepileptics, and you can see and so on. And when you look at dosage decrease or patients stopping this medication, this is pretty significant in this, difficult to treat population. So this is very promising. And again, I have seen this in my patients who've been able to get off of, not everybody, but many of the patients are able to get off medication. And then this is the wide range of dosing of CBD. So along the bottom here, you see dose of cannabidiol, and then you see how many patients. So for instance, dosing 15 milligrams, and this, by the way, was about 3 times a day. So there were 3 patients who ultimately took 15 milligrams 3 times a day. Here, if you go across, about 7 patients were taking 30 milligrams 3 times a day. But you can see 15 patients ended up on 60 milligrams 3 times a day, which if you buy a bottle of cannabis oil that only has 250 milligrams in it, and your child takes 60 milligrams 3 times a day, that bottle's not going to last you very long. And this is why we have to understand that a lot of the CBD that's available in the United States is not made for children who have epilepsy or autism, because often higher doses are needed and nobody can afford to buy 1 bottle of medicine that's going to only last you 2 days. And as you can see here, other patients needed much higher doses. The highest dose that I have a patient on right now is about a little 7-year-old who had severe aggression, self-injurious behavior, very, very difficult. And he takes 400 milligrams of CBD twice a day, and he takes 25 milligrams of THC twice a day. And he is doing spectacularly well. And when the parents had come to me, they had already tried cannabis. They were just afraid to go high dose, because who's going to do that without some medical supervision? I understand that, but understand that even high dose cannabis, extremely safe, and you really can't, get harmed. Of course, medical supervision is desired, but if you are struggling and have not seen low doses work, remember high doses may need to be used. When we look at the benefits, so what do we see? Less anxiety, less aggression, less temper tantrums, less self-injurious behavior, less rigidity, less stimming, better sleep, better speech, better focus, better school performance. These are all things that my families that I take care of have said to me. My child can participate in speech therapy now because he's focused instead of running around the room. My child has better eye contact. My child is, like engaging with the family. And again, side effects, they're temporary, they're reversible, they can be resolved by changing the dose, the product, or the timing. And, sometimes they're not resolved. And then we know that that particular product is not meant for that child. Okay. But remember, there's lots of different choices, which I'll show you. But increased restlessness and hyperactivity is not unusual. It just means you're not at the right dose or not on the right product. Increased emotions. I've seen some kids get more emotional, crying more. Some patients are having more meltdowns. And the other thing, of course, is impairment or intoxication. And if you take enough THC, certainly you can be impaired by it. And remember, we are never looking for a child to be impaired or intoxicated. What we're looking to do is balance out that endocannabinoid system so the child has better function, better quality of life, but without any impairment or intoxication. Now, we're going to move on to the cannabinoids. So this is a chart that I found, and you can see the website up to the top right, so thank you to them. This is how cannabinoids are made, the phytocannabinoids. So when I say phytocannabinoid, I'm talking about the plant cannabinoids. When I say endocannabinoid, I'm talking about the ones that we make in our cells, okay? So the plant compounds start, you have raw, you have heated, and aged, as you can see. So if you had a cannabis plant in front of you, a female Unfertilized female flower is the where these compounds come from. And the mother to them all, the mother compound is CBGA, and that stands for cannabigerolic acid. And what happens is, depending on the genetics of the plant, it goes to, it has these different enzymes. So you can see THCA synthase, CBDA synthase, or CBC synthase. And what happens there is that this CBGA is exposed to this enzyme and it changes. And so CBGA can change into THCA, it can change into CBDA, or CBCA, and often it does all three in the same plant, but usually there's dominance of one or the other. Sometimes there's an equal share of THCA or CBDA. We might call that like a half and half, 1-to-1. And what happens is that when this female flower is harvested, and if I were to test it in that raw state, it would have all the compounds in this A form: THCA, CBDA, CBCA, and CBGA. And then what happens? Humans heat up cannabis. So, you know, the first time I ever heard about cannabis was that my friend's brother got in trouble for smoking pot. Like, it's heating it. And then you hear about people baking it in brownies, right? Or baking it in cookies. What the heat does is the heat cleaves off a carbon and 2 oxygens off the chemical structure and converts the compound from THCA converts to THC, and CBDA converts to CBD, and so on with the others. So remember that THC does not come from the raw plant. CBD does not come from the raw plant. If you buy a bottle and it is labeled CBD or THC or both, by definition, that bottle was heated up. We used to think that the raw compounds were not biologically active, that you had to heat the raw plant in order to, quote, activate it to get it to work. And that turns out that that is not true. The raw compounds are quite active. And I use THCA and CBDA all the time in my patients. Remember too, that of all these compounds, the one that is psychoactive, or what we call intoxicating or impairing, is THC. None of these others really have, you know, brain altering, well, I shouldn't say that. CBD alters your brain, it's just not intoxicating. So psychoactive means that it affects your brain, but intoxicating or impairing. So CBD is not impairing. It just, and remember, now you know why. It does not bind to that cannabinoid receptor in the same way that THC does. It's that action at the receptor for the THC that causes that intoxicating or impairing effect. Now, I've put the red arrows on the products that are available in California right now. There's a lot on the market, and every time you turn around, something else pops up. I suspect that we're going to see, this is backwards here, it should be THCV, and then CBDV is also on the market, so I have to put arrows there. But interestingly, I use many of these in my patients with autism, because all of them have medicinal properties. Some, they overlap for some, and they some of them have their own medicinal properties. So let's compare CBD and THC. So as you can see, these both have a multitude of medicinal properties. Now, clinically, you can see here CBD has stops nausea and vomiting. That's been shown in studies. You also see that in THC. You see here stops nausea and vomiting. Clinically, I very rarely recommend CBD for patients with chemo who are taking chemo or for whatever reason have nausea and vomiting, because I just find it doesn't work that well. THC works beautifully at very low doses. So, you know, the way there's the studies show these kind of proven benefits, but then how we use them clinically is kind of like what I would call the art of medicine. But as you can see, there's a lot of overlap. But remember, from the slide I showed you a little while ago, that they do work differently, but there can be an overlap in how someone responds to them. And again, here, very important, CBD alerting and stimulating in low doses. When I hear that somebody took 5 milligrams of CBD and had a great night's sleep, I am a little bit suspicious of a placebo effect, because that is not really how CBD works. It's study after study after study shows that CBD is a little stimulating in low doses, and again, more sedating in higher doses. Both compounds are anticonvulsants. Both compounds help with anxiety and depression. Again, they work differently, but they have these overlapping effects. And looking at the other phytocannabinoids I mentioned, CBDA not impairing, what I've listed in the green box here is that CBDA, this is what we know from the literature. It's a potent anti-inflammatory. It can stop nausea and vomiting, and I actually have used it in patients where they either had THC tolerance or they were getting a lot of chemo and we had to add in a second compound. I have seen CBDA work well for that. And again, it's raw cannabis plant. That's all it is. Usually comes in a tincture form. There's in patients, I have seen it reduce anxiety and depression. And I have had a few patients have an anticonvulsant effect, although again, I will tell you this is not proven in the literature just yet. And by the way, these compounds are very much understudied. We do not have nearly the number of studies on these compounds compared to CBD and THC. So right at this moment in time, these compounds may do a lot more than what's listed here, but we just do not have the research yet for me to say this is proven. THCA I use a lot in patients with epilepsy and autism. It is not impairing. Low doses can be very effective for patients as an anticonvulsant. Remember, in the bottle, there's going to be a teeny tiny amount of THC in there. So when I share with people, oh, you know, the THCA really helped X patient, well, it may be the THC in the bottle as well that's helping. So we can't always say it's the one compound, because remember, these are whole plants kind of turned into a tincture or an extract, and there's a lot of ingredients. So we don't know exactly which one is working, and likely there's more than one working. CBG also not impairing. This stands for cannabigerol. Cannabigerol is interesting in that it occurs in a higher amount in the hemp version of cannabis, and it too is anti-inflammatory, reduces anxiety, depression, and I do have some patients doing quite well when it was added into the mix. And then down here on the lower left, I wrote benefits seen in children with autism. So again, this not in studies, just what my own clinical experience, what parents are reporting using these compounds. Less impulsivity, better focus, better speech, better mood, less aggression, less self-injurious behavior, and just happier. I know if you're here attending this lecture, you've probably heard of this from families, or you're using it in your child. I'm sure that you have seen some of these benefits. And again, we can't, there's a lot of media attention on CBD, but I will share with you, and remember, look at that study from Israel that only 50% of the patients responded to the 20-to-1. They had to add THC. And again, if they had expanded their study and looked at all these other compounds, what I guarantee that you would see is that layering these compounds gave added benefits. I have found that stacking them, multiple products working together, really seems to help. And CBD may not even be part of it. It's going to be part of it for some children, but not for others. Now, I just want to mention terpenes, and this comes from my friend, Dr. Dustin Sulak, who owns a company called healer.com, which is a wonderful program with information. Terpenes are the essential oils in the cannabis plant. It's why cannabis smells like cannabis. You're smelling terpenes, which is just a fancy way of saying essential oils. These essential oils are cross-species. So limonene is found not only in certain strains of the cannabis plant, but also in the rind of many citrus fruits. So pinene is found in pine trees. And if you've ever walked into a pine forest and you take a big deep breath, it's very invigorating, and that's pinene that you're smelling. Linalool is found in lavender. We know lavender to be anti-anxiety. So remember, when I'm talking about terpenes, there are certain strains, or what we call chemovars, chemical varieties of cannabis, that are being grown. It's kind of like different kinds of roses. I don't know anything about growing roses, but you know, they have different names, and they have, like, you know, famous roses. And it's this strain of cannabis, this chemical variety. It could be high in limonene, high in pinene, and low in linalool. You buy another bottle of cannabis, and that one's high in linalool and low in the other two. One may suit your chemistry better than the other. And it's very important to understand that these play a role in the outcome. When I talk to adult patients who say, I like this strain of cannabis, but I don't like this strain, and I look at them, and it's the same amount of THC in each one. The THC is the same. So what makes it different? It's the amount of, it's the different terpene profile. So it's very important to understand. I find just clinically, linalool is very important. It's anti-anxiety, it's calming. Beta-caryophyllene regulates inflammation. It helps bind to the type 2 receptors. I find that beta-caryophyllene is very important in my pediatric patients. And some patients do well with limonene and some don't. Some do well with pinene for focus and some don't. So if you're able to look at the terpene profile of a product that you're using, and let's say it works, it's important to say, okay, these are terpenes that are beneficial. And if something didn't work, it's nice to say, okay, this one was high in, let's say, limonene, maybe we should stay away from limonene. Maybe that's what's not making this particular product work for us. Now, in terms of products, I like to break the products up into categories. So there's high ratio CBD THC. So examples 25:1, like in the study 20:1, 18:1, all the way down to 10:1. That just means there's more CBD. So it's CBD dominant. These can come from hemp versions or from cannabis versions. And the definition right now, our government says less than 0.3% THC by weight is hemp. Anything over that is cannabis, okay? But let's say something is 0.29%. Is it going to be that much different from 0.3? Not really. So there is a role for hemp versions of these products as long as you test it. Remember, those are unregulated. Anything from a dispensary usually has been tested numerous times due to state requirements. But so it's always very important to understand the COA, which, by the way, I'm going to go over. I also categorize compounds as low ratio. So this is closer to kind of half and half, 4:1, 2:1, 1:1. There's THC dominant, mostly THC, or ratios such as 1:3, 1 part CBD to 3 parts THC, THC dominant. So, or 1:5, 1 part THC to 5 parts, 1 part CBD to 5 parts THC. You want to know what that ratio is. It's important. And then what I call monodominant, so singular dominant, CBG, CBDA, and THCA. There are combination products on the market. I put a little star here because I always tell people it's not great to start with that. It's, to me, I like to know exactly what each compound does for my patients. And starting with a combination product, if you don't have a good result, you kind of lost what happened, what didn't work. I'd rather rule in or rule out each single cannabinoid. All right, now let's talk about the COA. This is the certificate of analysis. It tests for many things: the cannabinoid potency, the terpene profile, the presence of residual solvents, presence of pesticides, whether or not there's microbial contaminants like bacteria, mycotoxins like mold and heavy metals. Please do not use a product that does not have a COA. And if you get a COA, I've had families where I said, oh, get the COA and I'll be happy to check it for you. They send me the cannabinoid potency and nothing else. So I don't know if it's great. It looks like it's got lots of CBD in it, but I have no idea if it's got heavy metals or anything else. So you want to make sure you get all of these parts of the COA, not just one part of it. Here, and I'm just going to go through, this is real life COA that came to my email from a family that I've been helping. And as you can see, this product has a high amount of THC, so 61%, and it's got 9.9% CBD. So this is what we would call a THC dominant, but it still has some CBD. And by the way, you can see it has CBN, it has CBG, and it has CBC. So this is a nice amount of cannabinoids. So this, you could call this full spectrum, okay? That at least has a number of different cannabinoids, not just one cannabinoid. Now here's pesticides. This product that this family sent to me fails for pesticides. So notice here where the red fails are multiple pesticides, and it's not a large amount, but it is enough for it to fail testing in my state. So if you look here, LOD means the limit of detection. So this is like the level at which anything under this they can't detect. The limit of quantification is when it's like they can detect it at this number, but really anything lower than that is very hard to, it's there, but it's not enough for them to quantify. But more importantly is the limit. So these are the state limits when you look under the limits here. So if you look here, let's look at one where the state allows a limit of, so look at this biphenazenate. If you can see that, it's 1, 2, 3, 4, 5, 6, the 7th one down in the left column. The limit is 0.1, okay? And this was found in this product. The test shows that there's 0.015 micrograms per gram of this particular pesticide, but it passes because it's under what the state set as the limit. And by the way, the states all set different limits. It's a little bit insane. Some states have very strict and some states are not so strict. I do not want pesticides in any of my patients' products. It is why would I give a product to a child daily that's loaded with pesticides? So to me, this is a deal breaker, especially when you have 1, 2, 3, 4, 5 fails in this particular pesticide testing. Here's microbials and mycotoxins. So aspergillus and some of these other compounds, these are contaminants that can make you sick. This particular product passed all of that. Mycotoxins is what we, certain types of molds, they also pass. And then if you look at heavy metals down here at the bottom, this failed miserably. The limit is 0.2 for arsenic and it's 0.54. That's what it tested at, so it fails, as well as lead. And this is a pretty high lead level. You see the limit that the state allows is 0.5 micrograms per gram, and this has almost 10 times that. So this is a product that when I shared with the family, I said, this is not something that would be safe for you to give to your child. So this is just an example, and I don't want to scare anybody. There are a lot more products that pass than fail, but you have to know. It's important to know, okay? And then residual solvents. So if I were to take some plant material and process it into an extract, I might use methanol or isopropanol or butane or some kind of solvent to do my extraction. And as you can see, this product passed, but there is acetone and also heptane, which again, I am not a fan of having anything test, even though it passes. And you can see the limit here, 5,000 for acetone. But again, there are products on the market that do not have any residual solvents, and those would be the ones that I would recommend over this type of product. Now, I'm just going to wrap it up here. Considerations. So I've already said one size does not fit all. The response is individual. Your endocannabinoid system is unique to you. Your child's endocannabinoid system is unique to them, and the way that they respond is the way that they respond, even if they have exactly the same symptoms as their best friend who responds to X product and your child doesn't. That is not surprising. I've already talked about the biphasic effects of CBD. Lower doses overstimulating, higher doses more calming and focusing. So Dr. Sulak, who's a good friend, we have the saying in the cannabis world, start low and go slow, but he has added on, and don't be afraid to push it. Don't be afraid to go all the way. So higher doses can be used, and you should not be afraid of them. But remember, if lower doses are aggravating to your child's condition, you can get the opposite. If you understand that, you can understand that you don't have to wait around. You can just go higher on dosing, okay? I do find that combination THC and CBD often gives better results by addressing more symptoms. Additional cannabinoids can often be additive in terms of, let's say, lowering, and you get, let's say, 50% lowering anxiety, maybe adding in THCA helps lower the anxiety more, or it can fill in gaps. So if maybe THC and CBD help with aggression, but didn't help with sleep, maybe adding something else in will fill in that gap. I will say that children are moving targets. They are constantly growing and developing, which is what they're supposed to be doing. So it is not unusual if you find a regimen that works, that 6 months later or a year later, that you may find it's not working as well. It's not the medicine. Your child is changing and growing. And again, they're supposed to do that. So it is not unusual that the dosing and cannabinoid combo may need to be changed as the child grows and changes and develops. Now, I usually start off with tailoring the initial treatment to 1 or 2 symptoms. So sometimes people come in and say, we are not sleeping, my child is not sleeping, I could deal with behaviors during the day if we could get some sleep, or the aggression and self-injurious behaviors out of control. So I try to address some of those symptoms up front first and then work on everything else after that. Because if you try to treat everything at once, it's a little bit like whack-a-mole, you may not get anywhere. And then I've put this in italics because cannabis treatment takes time. It's not magic. If your child has been living kind of out of whack with their endocannabinoid system for a long time, it may take time. There are patients who respond very quickly to cannabis. They're like, you know, at the top end of the responders, but there are kids that it just takes a little bit longer time. And I've had patients it takes 4 months. So you have to be willing to hang in there with it. It is very important to understand you're going to have to try numerous products. It can take months to kind of fall on the right product. If you find the right product right away, consider yourself lucky. As I've mentioned, multiple cannabinoids, the synergy can really help. I will tell you that I do not think that cannabis cures autism. I think it's one of the puzzle pieces along with therapy and diet and a whole bunch of other supplements. It can really, but it can be a very important part of the puzzle pieces to help kind of have a better quality of life and have a happier child. And then also be aware high doses may be needed due to severe endocannabinoid system deficiency. And also remember that if you take 100 milligrams, you do not absorb 100 milligrams. Cannabis is poorly absorbed when it's taken sublingually or through the oral route, which is how children take it. You only absorb somewhere between 4 and 20%. This is now some old studies, and we haven't seen any newer studies showing any differently, but that is why sometimes you have to go much higher, is to get that level up in the bloodstream to actually have an effect. And then last but not least, I have this thing I talk about in my book, rule it in or rule it out. You start with one product, start low dose, keep increasing the dose, looking for a dose that is beneficial. Often you have to pass up the dose to know, oh, that was the dose that worked better. If I went too much, he's too sleepy. You bring it back down to the dose that worked. Taking notes and having a log is very important. If you've ruled it out, it means no dose, high or low, of that particular product helped, and you might want to move on to another product with the same cannabinoid in it. Let's say a CBD dominant, you tried, it didn't work. You might want to try one other brand. Why? Because again, those terpenes are different by definition in different products. Or you could switch to another cannabinoid. Again, trying to be very regimented in your approach so that you don't end up all over the place and say, I don't know what worked and what didn't. If you've ruled it in, it means you found a dose that helped the symptoms. So I'll give you an example. I have a patient that we were crystal clear that a 1-to-1 ratio, half CBD, half THC, helped with sleep at night, but during the day it did not help. He was a little too sleepy. So we switched over to THCA during the day, and that's what helped during the day. And we started low dose and we titrated up, and we found, I forget what the dose is, but he had a dose in the morning, a dose around 1 o'clock in the afternoon. Gave him a great day, and then around 7 o'clock at night he took his 1-to-1 so that he could sleep 8 or 9 hours at night, because this was a kid who wasn't sleeping at all, maybe 2-hour stints. So you have to be willing to kind of, here's what's working and now let me add this in and see if that's going to work. Because if you already know, let's say, that first product and it's working well, you've seen it, now you know what that product does. Adding in a second product is only going to tell you what that second product does or what they do together, okay? Some common combinations, one I just mentioned, THCA during the day or THC at night, CBD during the day, THC at night, 1-to-1 day and night, lower dose during the day, higher dose at night. Sometimes a combination of CBG and CBD during the day, and you don't need anything at night. There's so many possibilities because so many products, but if the one thing I can share is if you're patient and you take notes and you kind of have a regimented approach to it, you are likely to find something that works. And when we look at the numbers that I just gave you with all of these various patients, somewhere between 60 to 80% of patients are going to respond. The odds are in the favor of responding rather than non-responding. And certainly I will share with you too, in terms of side effects, it's a very acceptable side effect profile, and by tweaking things, you can avoid or mitigate those side effects. All right, and these are just some of the patients that I have been so honored to take care of. So we're gonna stop there and we'll go with some questions. So I'm ready for questions, Erica.
Thank you so much, Dr. Goldstein. That was amazing, as usual. So we have a question. Have you found combining other agents with cannabis to be compellingly and consistently helpful, for augmentative therapy? If so, which are your favorites?
Well, I'm not sure what you mean. So maybe you're talking about supplements,
It sounds like
maybe?
that.
Yeah,
Other agents, so supplements or treatments, I guess.
right. So I do have a fair amount of patients that use products with fish oil. Remember, feeding that system. Okay, so fish oil is very important because we all know that we're all out of balance on our omega-3s. And kids with autism are very picky about the foods that they eat and are clearly likely to be deficient there. So I usually tell people that fish oil can help. I have found that patients who do like a gluten-free, dairy-free, high-fat diet, high healthy fats, often do well with in combination. There are products out on the market like GABA, which are very calming, and I have seen some of my patients do well with that. In addition, I'm just trying to think of some other supplements that some of the families use. You know, there's a product on the market called NeuroNeeds, which has 33 different supplements kind of mixed into a powder. It was developed by some doctors who are neurologists, autism specialists, which some of my patients have found to be very helpful for hyperactivity and focus, in addition, in combination with cannabis.
Thank you, Dr. Goldstein. Also, do you run LFTs prior to or monitor when using cannabis?
It's a great question.
Yeah.
Yep. So LFT stands for liver function tests. So there is some evidence from the Epidiolex. So let's just talk real quick. I didn't mention Epidiolex. Epidiolex is a prescription only CBD pharmaceutical made by a company called GW Pharma. It was approved in 2018 and became available last year, 2019, for children with severe epilepsy. So Dravet syndrome, Lennox-Gastaut, and just recently they added in tuberous sclerosis. It was a Schedule 5 drug on the Controlled Substance Act, and this year they took it off, so it's just like a regular prescription now. It's not abused, it's CBD. But it is plant-derived, it's not synthetic. So what happens is the company pulls the CBD out of the plant, and it's a 99% pure CBD product. Because it has been stripped of most of the terpenes and the other 500 plus compounds found in that whole plant cannabis, you have to use pretty high doses of the CBD to achieve similar results that you might get with whole plant. So this question about liver function tests, when they were doing the Epidiolex studies in order to get it approved, FDA says you have to give really high doses to kids so we can see what's safe and what's not safe, right? So in those trials, they found that in some of the patients, and remember, these are children with severe, devastating epilepsies who are all of them were on other medications, seizure medications. And one particular drug called Depakote, which is called, the generic is valproic acid, can harm your liver. It's known these kids who are on Depakote get blood tests for their liver every 6 months, okay? Anyway, when high dose CBD in these trials was added, they saw that the combination of Depakote and CBD together elevated the liver, what's called transaminases, the liver enzymes, okay? But it was only in those patients with Depakote. Now, what's interesting is there's since been another study that came out that showed elevated liver function tests in people taking, again, Epidiolex, or this, you know, because they're using Epidiolex now in other trials for other things. It's approved for certain epilepsies, but now it's being used for other trials. In fact, they're using it in an autism study that I know of. But again, because it's pure CBD and you have to go very high, the big question is it really the CBD? So there's a couple of caveats here. In my practice, I have not seen elevated liver function tests in my patients. They all get blood work and we just don't see it. For the most part, they get blood work. A lot of the kids with autism can't get blood work because they have to be sedated to get blood work, and we're not going to do that to them. And often they're not using mega high doses, okay? And they're usually not on other drugs that also interfere with the liver. Dr. Russell Sinedo, who was one of the co-authors of an article I published with Dr. Sulak in 2017, followed blood levels on children in his neurology practice out of Seattle Children's, who were on very high doses of CBD in addition to seizure medications, and he did not see any elevation. So I think it may be due to this very elevated use very high doses of CBD. And so it's a very low number of patients that have this issue. One thing I just also want to share is that you can often get similar results if you have high CBD, low THC, and you have to do really high doses. Sometimes using a lower ratio, a lower amount, you get the same results. So it doesn't have to always be one or the other. It is important to try different combinations in different doses. And the other thing about really high CBD, again, so if you walk away with anything from my answer, it's usually really high doses in combination with Depakote that cause the issues, okay? And by the way, in the Epidiolex studies, they took away the Depakote and the CBD in these patients, and their liver function tests completely normalized. And then in some of the patients, they re-challenged them with CBD, and they did not have the abnormal blood test. So it clearly was that combination, okay?
Thank you, Dr. Goldstein. I think this is a really important one. A lot of pediatricians ask this when parents are having discussions with them. Is there a long-term risk of psychosis with cannabis?
Yeah, so it's a great question. So CBD is actually an antipsychotic. So if you have CBD in the mix, it would be very unusual for someone to have a psychotic episode. However, in one of the Israeli trials that I showed you, there was a girl enrolled with autism who did have some kind of psychotic-like behavior. They did not describe what it was. Was she hallucinating? Was she have delusions? Did she have that before? What other medications was she on? So I don't know the answer to those. But once she was taken off the cannabis, and this was after she fell into the group where they added more THC, and it was the addition of THC, and one also wonders, did she get the wrong dose? Did she get too much? Because I will tell you, it can look like psychosis if you take too much. If you talk to any adult who took too much of the edible, they're hiding behind the couch thinking, the cops are outside, and that's a delusion. So the big question is, does that increase your risk for, let's say, schizophrenia or psychotic behavior later? There's no evidence to support that. In my practice, if I see a child, if a parent reports to me that their child is out of sorts, over emotional, acting, for lack of a better term, crazy after getting a new product, that is not for them. And we just move on. There's no reason to make a child uncomfortable. And sometimes you don't know until you give it. But that's the risk with any medication. Remember too, and I just want to be very clear about this, we have no long-term studies. This is new. My first pediatric patient came to me in 2013. That's only 7 years ago. Now, I will share with you that I have kids who have been in my practice, have been on cannabis for 7 years, who are thriving. They're doing beautifully. They're achieving in school. Their speech is better. They're learning math. They're just making great developmental progress. So I don't think that we're going to see something down the line, but can I guarantee it? No, because it's still brand new.
Thank you very much. With respect to blood tests or lab tests, is there a way to determine how one would respond, better or worse, to CBD or THC, or is it purely trial and error?
Unfortunately, right now it's trial and error. You may have heard about some of these kits that are out there where you can send in a swab and get some DNA result that says you may be more likely to respond to higher CBD, or that you have a predilection for THC dependence. The research is not there yet. These companies have, I will say, I feel that they have kind of jumped the gun. There was one company that showed me a sample report, and in the sample report it said, this person's DNA shows that they have a predilection for THC dependence. Okay, a child with autism is not an adult or a kid smoking, or a teenager smoking pot behind the high school. I mean, medical is not equal to recreational use of cannabis. They're two very different things. So I feel like that if a parent who is new to this and nervous about it saw that, they'd be terrified. But that is not how the child would be using cannabis anyway. They're not quote, self-medicating or recreationally, experiencing cannabis. You're using products that usually combine a multitude of cannabinoids in dosing that would be considered medical. So it's just not there yet. And if you're curious to do it, I would say do it, but kind of take the results with a grain of salt. At this point, unfortunately, it's trial and error.
Right. Thank you. Have you had any success in treating OCD?
I have had success in treating OCD. I will share with you that although there are a few patients here and there that will respond to a CBD dominant product, I do find that THC and THCA definitely play a role with what I have seen, a better result, having it in there in some significant amount rather than just a small amount when you're using a CBD dominant. I also noticed that with tics, ADHD, and again, this is just my observations. There's always outliers. There's always going to be, in fact, I wrote in my first book about a boy who had Tourette syndrome and did very well with a very well-known 25-to-1, 25 parts CBD, 1 part THC. But again, overall, I do always explain to families if we're treating something like tics, OCD, Tourette, that we can start with a high CBD, low THC, but don't be surprised if I recommend adding in THC or THCA.
Okay. Thank you. What about Tourette's?
Same thing. So
Okay.
same answer.
That's
Yeah.
what I was
To me, it's very effective. By the way, there's a researcher in Germany. Her name is Kirsten Mueller-Wahl. She has led the way, and I write about it in my book. I summarize all her research. She is a psychiatrist who has done numerous studies to show that cannabinoids can treat Tourette syndrome and really give excellent quality of life, especially when pharmaceuticals have not helped. She is, I bow down to her. She has really led the way, and she is unafraid to publish those results and to make a difference in people's lives.
Awesome. I swear this is not my question. Do you use Alera Hope products for patients with autism?
Okay. Okay.
I swear
So
no.
that's not no problem, Erica. No. So we do not have those available right now in California, as far as I know. Is that correct, Erica?
That is correct.
Okay. So we do not have those products available. I have seen the data on those products, and they work, and there are patients using them. And remember, they're in ratios, I think 1-to-1 and 5-to-1 or whatever. It's 5 parts THC to 1 part CBD and then a 1-to-1. And these are ratios that we use here in California. They're just not that brand. And there's no question that those products can work. Now, one thing I didn't mention, which I should have put a slide in, I'm going to do it for the next time, is I just want to mention tolerance, just because we're kind of talking about products with THC. Okay, so you want to ask the question and I'll answer, or?
Yeah. There's a lot of questions.
Okay.
Do tolerance issues arise in your experience? Do potent CBD products wear off and require more over time?
Okay, so it gets tricky. So tolerance is really only something that we see with THC. So what does tolerance mean? It means you need a higher dose to get the same effect. And understand, now you guys have a visual of that cannabinoid receptor sitting on the cell wall. What happens is if you inundate that receptor with THC over and over and over again, let's talk about a chronic heavy, smoker of cannabis, right? What happens is that receptor finally says at some point, there is just too much hitting me, right? Too much binding. And what happens is it's almost like like self-protection. The receptor actually migrates away from the cell wall and hides inside the cell. It is no longer available to have THC bind to it. That's not good. You do not want that, because where's your endocannabinoid going to go? You make your endocannabinoid, but where'd the receptor go? So we call that down regulation of the receptors, less receptors on the cell wall. But the beautiful part of our endocannabinoid system is if you abstain, those receptors kind of get an all clear, let me pop back out. And there was a really elegant study that showed that They took chronic heavy cannabis users, they gave them radioactive THC dye, and it showed very low number of receptors, and they locked them in a lab, and they paid them, compensated them, but they locked them in a lab for 28 days, and they scanned them at day 0, day 7, day 14, day 21, day 28. And as they scanned them, what they saw was more and more receptors popping out. And by day 28, their receptors were similar numbers to someone who had never used cannabis before. So you see, the system is very flexible. CBD does not, remember, it doesn't bind to that same site, as you now know, so it does not cause tolerance. What's fascinating about CBD is that a couple of things. One is that I have seen reverse tolerance. What does that mean? Lower doses needed. So what happens is maybe a child's endocannabinoid system gets into balance and they just don't need as much. Okay, I've seen that with pain patients. I hear it all the time from my patients who say to me, I just don't use as much as I used to. And they think it's their choice, but it's because they feel better. Why do they feel better? Their endocannabinoid system is working well, is functioning well, okay? That's number one. And number two with CBD is that, remember, especially for epilepsy, maybe with autism, if it is a weight-based dose and your child needs X milligrams per kilo of body weight and your child is growing, you may have to escalate that dose to keep up with, so your child doesn't outgrow the dose. That is not a tolerance issue. The studies on the GW pharmaceutical product called Sativex, which I didn't talk about, it's not really relevant here, but it's a 1-to-1 ratio CBD THC that's approved in, I think, 30 countries, not in the US, for multiple sclerosis, for spasticity of multiple sclerosis and advanced cancer pain. Because it was developed many years ago, there's now a large body of data looking at the results, and that 1-to-1 ratio did not cause tolerance. The presence of CBD, remember I told you it's like the traffic cop regulating the receptor, it appears to help keep the receptor from developing tolerance to the THC. So I very rarely use THC as the only medication in pediatric patients because of the tolerance problem, that you lose the effect over time.
Yeah, thank you. I'm going to combine two questions about terpenes. Do you ever just use terpenes? Are they available outside of cannabis to use terpenes as a treatment?
Yeah, you can buy medical grade terpenes online. There's a lot of companies that actually buy medical grade terpenes or, food grade terpenes.
Right.
And then they kind of, lack of a better term, spike their cannabis to enhance. There is a company here in California. Prior to 2018, we had kind of the Wild West system out here where you could literally call a company and they could put a concoction together for you and then sell you that. So there was a company that was doing that for a lot of patients. Unfortunately, now it's difficult to do under the new medical cannabis laws, but what they did was they created, quote, a sleep formula. So what was the sleep formula? It was spiked with extra myrcene. Myrcene comes from hops and rosemary. We know myrcene plus THC equals sleepy. Okay, so they were adding in, so they had a strain that was high in myrcene, but they added more for those people who struggled. And they had this great sleep formula that parents were using. And I don't think it's still available, but when you look at the so there's a product on the market that's called Sleepy Time right now. I'm not going to name the brand, but if you test it, it is chock full of myrcene. So I think I personally have not recommended to buy extra and supplement, but I have heard of parents and patients doing that.
Thank you. So you clearly advocate for tinctures with much clinical success. What are your thoughts with RSOs or other kinds of tankers, syringes, things like that?
Okay, sure. So the reason I like tinctures is because when you're using like a 1 ml syringe to draw up the oil, you can be very accurate in dosing. If, let's say you buy a product that like edibles, let's say, and they come in 10 milligrams. I mean, you can cut it into quarters, but less than that, you're going to have a hard time dialing in, right? So if I took a 10 milligram edible, like a little square gummy, and I cut it into quarters, I can do 2.5 milligrams. And I guess you could cut that in half and get 1.25 milligrams. But I just find with tinctures, you can be a little more accurate in dosing and really dial in between like 1 milligram and 1.5 milligrams. The problem with RSO, understand what RSO is. RSO is the same as a tincture. It is just a different concentration. Milligrams is milligrams is milligrams. So if I have, and I write about this in the book, there are diluted products. The standard should be how many milligrams per ml. So if you have 10 milligrams in 1 ml, right? If you think about I wish I had a 1 ml syringe to show you, but you could do 0.1, which is 1 milligram. 0.2 is 2 milligrams. All the way up to 1 ml is 10. If it's concentrated, usually it's 25 to 50, maybe 75 milligrams in 1 ml. If you have 50 milligrams in a 1 ml syringe, 0.1 is going to be 5 milligrams. If you want to give your child 1 milligram, that's going to be very hard to measure. So the more concentrated, if you're at a higher dose, that's better. You get to take less volume, but you can't really measure low doses. What is RSO? The other term for RSO, if anybody's not knowing what RSO, that's Rick Simpson oil. It's just kind of the name of an oil, a concentrated oil after this guy who in Canada who kind of was one of the first people to put it out there. It's also called FECO, F-E-C-O, full extract cannabis oil. Those usually have 100 or more milligrams per ml. Makes it very difficult to measure low doses. I only use the FECO or RSO in my cancer patients when we're giving mega high doses. I have hardly a few epilepsy patients, adults who take or teenagers taking very high doses who prefer to take it that way because the volume is smaller. But in the beginning, when you're first kind of sorting this out, RSO is not the proper product. It's too many milligrams. It just, you don't have control over the medicine.
Very strong. Thank you. Do you work with patients who don't live in California? Would you consult regarding products, dosing, etc.?
Right. So I have been told numerous times by my attorney that I am not allowed to practice medicine outside of California. And Zoom and Skype or anything telemedicine, actually, the way that they look at it legally, it's where the patient is, not where the doctor is. And interestingly, I know doctors in California who do practice, help, let's say, cancer doc specialists in cancer that help patients outside. But as my attorney says, you are not talking about medical marijuana Schedule I substance. So do not do that. I did do it, but I don't do it anymore with the new laws.
Okay.
And I'm sorry for that.
We are too. Thank you. Have you found children who use cannabis products have less positive effects on their GI system? So maybe we can even broaden that to say, there's a lot of comorbid symptoms with autism and GI tends to be one of them. So how have you seen improvement there or not?
Right. So I have seen some patients have tremendous, it's again, not across the board. I've had a lot of families will say, all the gassiness and discomfort and the constipation resolved with when we added in cannabis. And that's not why they're coming to see me, but it's kind of this nice perk that they're getting. But I've seen some patients actually either not get better in terms of the GI or actually get worse. And my suspicion is, and you have to remember what I said in the beginning, was that CBD, THC, they're kind of indiscriminate. They don't only go to the receptors in the brain. They don't only go to the receptors on the immune system. They go to any receptor that they find. This is why there's a fair amount of interest in what we would call drug development, kind of like the idea behind Epidiolex, although CBD, when you're giving it to a child with epilepsy, is going all over. But there are companies now looking to try to what they call peripheral restriction. So only target the CB2 receptors in the body and they don't go to the brain. And so this is why there's a fair amount of this interest in using cannabinoid medicines in developing drugs based on these compounds to be more specific, because when you're using whole plant cannabis, there is not a lot of specificity. It can, if we trigger those receptors and it goes in the opposite direction, it might make your child worse. Again, trial and error.
Thank you. Are you aware whether anandamide deficiency has been seen in any other pediatric conditions?
The only studies we have are those couple for autism. Again, it's not something that is, now in Israel, they may have done the study and not published it because like they're way ahead of us there in terms of research. It's interesting, you know, patients in California can get cannabis very easily. We have, you know, obviously a legal state, but no research is going on. And in Israel, it's the opposite, all this research, but patients are somewhat restricted. So it's, you know, we each have our issues. But they're kind of leading the way. I suspect that we will probably see some more evidence of anandamide deficiency in other conditions. But in pediatrics, the only ones I'm aware of are those two studies that I showed you.
Okay. I'm thankful for your time, so I'm just going to.
It's okay. I'm good.
Okay, good.
Okay.
We already did that one. Okay. Is there a negative feedback mechanism affecting the levels of anandamide? Is there a negative feedback?
That where you might produce less, I think, I'm not sure how to take that, but let's put it this way. If you are, if the message is being sent, trigger the cell to say, turn on the factory, there is, your body will make anandamide if the machinery works. Okay. There is evidence from a study about 10 years ago where they took patients undergoing brain surgery, and this was in, I want to say Austria, it's European country somewhere. They took patients undergoing brain surgery for epilepsy, and these patients generously donated a piece of tissue from their brain to the scientists, who then compared it with cadaver tissue from someone who did not die of a neurologic disease, no known neurologic disease. And what they found in the patients with epilepsy is 60% of them had an abnormal number, or 60% less of the enzymes that make anandamide. If you can't make anandamide, you can't make it, right? It may not be just dietary. Maybe you don't have the machinery to make it. The factory's broken, right? And is that genetic, or did it break somewhere along your lifetime? Again, we don't know, because we're still, you know, when you think about it, most of the action is taking place in the brain, and we don't get to go in live people's brains very often. Right. So it's the research is somewhat hindered by that. I mean, that's why they use animals mostly. Right. But I'm not sure I understand the question, but it doesn't appear to be that your body kind of turns off your anandamide. It's either you have the machinery to make it, as this is as far as we know right now, you know, December 2020, you make it if you can make it, and you may just make some and not enough, but it doesn't appear that there's any negative there. Yeah, I hope I answered that okay.
You did. I think I know who's asking. I think you did. How vigilant or cautious are you for CYP interactions for patients on psych agents? Onfi is well known. Any others in particular which have rendered bad results, or are these overblown concerns?
Right. I wouldn't say it's overblown. I would say, of course, you have to be aware. So remember, Onfi is the drug called clobazam. There's real no danger there. It's just you can get sedated, overly sedated, zombified. And if I am increasing CBD in a patient and I know they're on Onfi, and the parents call me a week after we just increased and we're at a, you know, pretty good level of CBD, and I've left the Onfi alone, because what we're trying to do is see what CBD can do for that patient, and they call me and say, you know, our child's sleeping all day, then I know we've hit that critical point. It's not dangerous. 40% of the patients in one of the Epidiolex trials required a reduction of their Onfi dose. Now remember, in real world, your neurologist might say, too much CBD, leave the Onfi alone, because they're more pharmaceutically oriented. But remember, when they engage these families to be in the Epidiolex trial, they don't want them to drop out. They want to run up the Epidiolex flagpole. So they were willing to lower the Onfi, right? So that these patients could stay in the trial. Remember, what happens in a trial doesn't always equal what happens in real life clinical situations. So I don't find Onfi to be dangerous. Depakote, which I've already mentioned, the combination of Depakote and CBD, of course, these children, like I said, are getting liver tests anyway, usually every 6 months. They usually have a baseline before they join the practice. In my patients with autism, unless they're on a drug that I'm really concerned about, I don't usually worry too much. And usually in my practice, nobody's coming in saying this drug works great and we want to stay on it. It's usually, can we get off of it right now, you know?
Right. Thank you. We have a follow-up to the feedback. She qualified by saying negative feedback mechanism given the overexpression of CB2.
Oh, I see. I see. So nobody's ever looked at that. So we don't know. But I've always said, like, wouldn't it be nice to be able to measure success? So take children with autism who are known to have elevated type 2 receptors, treat them with cannabis for a while, and then look and see what happened to the receptors. Did they normalize? Wouldn't that be a great study to do?
Awesome. Have particular terpenes shown up yet as beneficial? Are there any studies tracking terpene data? I wasn't a believer in terpenes after having my boys on for a year. We found a product that is not a very high dose, but the difference is so dramatic. The benefits have actually shown up my son's assessments, terpenes. She's excited about terpenes.
Yeah.
Do we have any studies on that, or what are your favorite terpenes?
No, I mean, so there's an article that Dr. Ethan Russo wrote, I want to say 2011, called Taming THC. It's free online.
Okay.
If you Google it. So it's called Taming THC, and I forget the subtitle, the phytocannabinoid terpene synergy, something like that.
Mm-hmm.
He goes in that article, and you know, I summarize it as well in my book. I talk about the terpenes at the back. There's a terpene chart that shows all the different terpenes and what they do medicinally, where they're found, maybe what strains that they're found in. But Dr. Russo's article still stands today. It's quite good. It is extremely important. And the unfortunate thing is when you buy a product, often you don't know the terpenes, or the company says, oh, we haven't tested it.
Right.
So it's not quite rigid science yet, but obviously this person who's asking the question has paid attention. And I have had patients tell me that anything with limonene makes their child bounce off the walls. They never go there because it's kind of a little bit of an up. It helps with depression, right? So it kind of is uplifting, and it may be too stimulating. I've had other families say, well, you know, we found something that's very high in beta caryophyllene and linalool, and boy, is it's working great. And I've even had parents say, you know, I tried the oil that my son uses and it just puts me to sleep. How come it doesn't put my child to sleep? Well, your child has a neuroexcitatory condition for which, let's say, linalool, myrcene may pull them back to kind of be in kind of a more typical, not on hyperactive mode. And for you, since you're not hyperactive, you're starting at the typical and you're being pulled down further, right? So you have to remember the brain that the compounds are going into is different than your brain or different than somebody else's brain. So I do think the terpenes are very important. It's very hard for me, though, to follow all the terpenes in these products. I try to get things tested and share those tests with families so that they can kind of cross off terpenes or circle them as good, cross them off as bad. Sometimes it's hard to figure out.
I think in a lot of states that have medical programs that require testing, the terpenes should be listed on the packaging.
Right, California doesn't require it.
Right. And then another follow-up to the terpene question, do various terpenes have an effect on individuals who are phenol sensitive? If so, how do you rectify that? So are they phenol-like?
I don't know the answer to that question, I'm sorry.
Okay. Thank you. We have just a few more here. How much does inflammation play a role in autism? You mentioned mycoplasma and pesticides, and separately GI distress.
So what we know, and there is literature to support this, is that, remember, inflammation is determined by what we call your immune system. And we know that children on the spectrum have abnormalities within their immune system. Some of that's manifested by, you know, frequent illnesses or, you know, ear infections or sinus infections, that kind of thing. And other children, it's just manifested by, like, you know, if you were to check, you know, high levels of inflammatory markers. And it's unfortunate that nobody really is addressing the level of inflammation when we're talking about treating, and epilepsy as well. Children with epilepsy clearly have what we call neuroinflammation. It's well documented in the scientific literature. And again, the standard types of treatments don't address the inflammation. And you can do a lot with dietary right? Controlling inflammatory foods and, again, gluten-free and dairy-free and sugar-free and all those things that you might want to do, or the GAPS diet or whatever it is that works for your child. However,
phenols like that.
Yeah, you have to have, for some patients, you have to have anti-inflammatories, and Mother Nature gives them to us. Turmeric is anti-inflammatory, right? Curcumin. And all of these compounds are highly anti-inflammatory, cannabinoids and terpenes. And when you look at some of the research on the terpenes, some of them have not been researched, but the one thing we know about them is that they are anti-inflammatory. So I do think inflammation plays a huge role in neuroexcitatory conditions. I think diet plays a huge role, our environment. As one oncologist said to me, we live in a cesspool of chemicals. By the time you leave your house in the morning, well, before COVID, you may be exposed to 300 chemicals before you walk out the door. So it's something that we all should be paying attention to. And I really do feel like cannabis addresses it. And it may not be a full, again, puzzle pieces.
Right. Thank you. Please ask, have you used LDN and cannabis for immunomodulatory benefits? These are immune supportive.
Right. So LDN is low dose naltrexone. I have very little experience with it. I have used it in 3 patients total. So I am not an expert, but I have seen, and all 3 patients had very severe autoimmune disease and were kind of at the end of the line. Cannabis was helping a little bit. And I felt comfortable enough with these patients, because they were my long-term patients, to try LDN, which you have to get from a compounding pharmacy. And, that's a whole nother, I bought the book and read it, and I talked to people who recommend it all the time and tried to do the best I can. But I have seen it work in these 3 patients. That's my N of 3, and I don't have much more, but I do tell people that it's interesting that cannabis and LDN have the same kind of history. Nobody wants to believe that it works.
Right.
Quote, conventional doctors look at you like you're crazy when you bring it up, but there is valid data, valid science to support the use.
Thank you. You stated that endocannabinoid deficits in parents may be present in children as well. Could that indicate that autism may be genetically inherent? I guess that's kind of fun.
Yeah, I mean, so when I can't say about autism, but about endocannabinoid deficiency. When I meet someone who has fibromyalgia or migraines, I'll ask a family history. And sure enough, mom has migraines, dad had irritable bowel syndrome, sister has fibro and migraines, and
right.
They just seem to run together. And so it makes sense that maybe in the coding of the part of the DNA that codes for your endocannabinoid system, it's a little bit off. There is research to show that there's some evidence of this. I can't say that your imbalance in your DNA cannabinoid system coding is what caused your child's autism. And I think that's a leap. But certainly we know that there's a multitude of conditions that have been shown to have genetic, like what I showed you, genetic expression is off for the endocannabinoid system.
Okay, thank you. There's 2 more.
Okay.
What is your favorite for addressing OCD? Your favorite, I guess,
Cannabinoid?
Such as observed in pandas or PANS-like conditions.
Yeah. So I find pandas really hard to treat. It is very difficult, and I'm always, I have a lot of empathy for families who have a child with pandas. It's so difficult. I have had some patients respond with pandas with very high CBD, low THC, but we're talking high doses, 300 milligrams twice a day, 400 milligrams twice a day. Again, in those very high doses, it might make your eye really sedated, can't keep your eyes open, but in someone with a really severe neuroexcitatory condition, it kind of brings them back down to kind of a more, base level. I also find that THC plays a role. THC is calming. We think about someone, let's just, someone who smokes a joint and just kind of chills out. That's what the THC does for a lot of people. Certain strains can be kind of agitating, but many strains are very calming. So when you ask me like, what's my favorite, it's very hard to say because I approach every patient I try to approach, but like, let's say somebody's pandas is really out of control. Before kind of trying to figure out a high CBD, low THC, and have to start low and titrate up. And remember, I showed you there's a very wide range of therapeutic dosing. So like we start down here, it can take forever, what feels like forever, to get to a high dose. I might start a patient at a 1-to-1 ratio because I know THC is likely going to help. And if we can get things under control and get life a little bit better, it buys us some time to be able then to go kind of revisit CBD if it's needed. Remember, you know, I don't have a crystal ball, so I can't tell, but if there's aggression and a lot of agitation and a lot of staying up all night and a lot of pandas-like behavior, I am more likely to include a fair amount of THC in the picture.
This one is, I've tried many products and have found hyperactivity to be a problem. I've increased THC and found it to make my son high, intoxicated. Mm-hmm. For what you're saying, it sounds like I need to significantly up CBD. Is there a brand you recommend starting with? This is a 17-year-old boy.
Okay, so I am not allowed to recommend any cannabis products specifically. So that's, unfortunately, I can't do that. However, let's talk about like what maybe a CBD low dose versus high dose. So for some patients, it's about 50 milligrams. And again, I do find that most of the families that do this on their own are giving 25, 30, 40, maybe even 50 milligrams, and they're seeing this overstimulation high dose. I'll share with you, I had a young man that came to see me with very, very severe autism, one of the most aggressive, kind of violent teenagers I've ever come across. And the dad had done this terrific job, even had consulted somebody else before seeing me and tried so many different products. And as he's listing, and I'm writing them out, like we filled a page, I'm like, oh my goodness, what am I gonna do? How am I gonna help this family? It dawned on me, they never tried high dose CBD, ever. So the first thing I did was, you know, I said, starting tomorrow morning, 100 milligrams 3 times a day. Let's just see. And within 2 days, all of those behaviors were significantly down. Wow. Tremendous results. He had tried everything under the sun, but he never crossed his mind to try high dose. There is really no danger in giving a teenage, you know, a big teenager, hundreds of milligrams. And I'm not going to give you dosing advice through this portal here, but what I've noticed is nobody ever does hundreds of milligrams on their own. So, and maybe you have, but what I would say is a high CBD, low TH, 20-to-1, 18-to-1, 25-to-1, and go for the higher doses. Just go for it. Don't be afraid. If it makes him too sleepy, okay, now you have your you know, this is too much, stay under that. Now you can tiptoe backwards. And I usually like to tiptoe up, but sometimes because of necessity and severe extreme behaviors, we have to start higher and back up. So, and that's okay. There's no right or wrong way to do this other than underdosing.
Right. Okay. Well, thank you so much, Dr. Goldstein. Is there anything you'd like to leave us with?
No, I just want to say that, you know, I joke around that cannabis is like a cupcake compared to pharmaceuticals. However, don't feel like you failed if you have to have your child on pharmaceuticals. I've had families come through my practice and cannabis only gave them, let's say, you know, 50% improvement, and, you know, the behaviors and so on and so forth were just too difficult and they had to add a drug in, and I could see it on the parents' face that they felt like they failed. And that I just don't want people to be like, oh, how come it's working for everybody and not for us? You don't have any control over that. You just do the best you can with your child, but definitely include cannabis if you see benefits, and don't be afraid to use it. There should be, like my family jokes around that if you unzip me, there's a chicken inside. I am a conservative kind of I was an ER doctor. I'm fearful of everything out there because I've seen it all. You know, my poor son, he gets on a skateboard and I'm envisioning head trauma and all of that. It's really very, very safe. So don't be afraid to try it. Try to get some advice from somebody who's been there before you. Try to get a doctor who has, you know, I know Erica knows doctors that can help you in various states and so on. But yeah, don't be afraid to try it. History and stigma is it's outsized compared to actually what it is.
Thank you. I actually have one last question that you just triggered me to think of. But so what do you do? So we do have some doctors, but we don't have you in the rest of the country. What do we do when our doctors are weary or they don't know exactly what to do? What advice do you have for us as parents?
Well, I mean, so educate yourself, go attend conferences like this, you know, read my book. Dr. Sulak has tons of conferences, you know, join groups like yours. Yours isn't the only group out there. There's lots of groups out there to join where people can try to help you sort out, you know, what to do. And if you get to a point where you need help, you know, you're going to have to probably seek out either a cannabis nurse. There are cannabis nurses out there as well. Yeah. That don't seem to have the kind of restriction that I have where they might be able to help you. And don't give up, just keep seeking help. It's not easy. I'm going to share with you, this is neither epilepsy or autism is easy to treat. And, but don't give up because there's hope out there. That's the name of your group. So there you go.
Yes. Well, thank you so much. We're so grateful for your time. And everybody, definitely get a copy of Dr. Goldstein's book, and we will follow up with the winners of the signed copies in an email in the beginning of next week. So,
all right. Yep.
Thank you
Sounds
again.
great. Okay. Bye, everybody. Have a good night and stay safe.
Bye. Good night.
Bye-bye.